but you need maybe the sound. Should I sit somewhere to the side?
Tes, tes. Oh, oke, ya kita mulai ya. Bapak Ibu sekalian, selamat pagi. Assalamualaikum warahmatullahi wabarakatuh. Ya, selamat datang di mata kuliah Informatika Kesehatan yang merupakan bagian dari mata kuliah wajib bagi sebenarnya mahasiswa S2 HPM ya, kelompok HPM. Itu ada SIMKES, ada minus MMR saya kira. Jadi ada SIMKES, MKO, MAK, KMPK ya. Yang dari SDM ada nggak ya? Masih ada nggak ya? SDMK? Nggak ada ya? Ya, jadi prinsipnya mata kuliah ini adalah nanti memperkenalkan kepada Bapak Ibu untuk ya mengetahui lebih dalam tentang informatika kesehatan, apa itu informatika kesehatan dan seterusnya. Nah, tetapi yang menarik bahwa dalam mata kuliah ini kita juga menyebarkan mata kuliah ini ke teman-teman yang di luar dari FKUGM, di luar dari Bapak Ibu sekalian. Jadi di mata kuliah ini kita kembangkan konsepnya menjadi MOOC, jadi Massive Open Course, yang itu diikuti oleh lebih dari 300 orang se-Indonesia, baik itu ada yang S1, ada yang S2, ada yang diploma, ada yang S3, dan bahkan ada Bapak Ibu atau teman-teman kita yang lain dari institusi lain. Ada dari praktisi dari rumah sakit, praktisi dari dinas kesehatan, praktisi dari BPJS kesehatan, bahkan peneliti di luar kita. Nah, sehingga Bapak Ibu nanti selama mengikuti perkuliahan ini akan berinteraksi dengan banyak orang di luar sana. Nah, saya kira Bapak Ibu kemarin sudah mengikuti ada sesi diskusi perkenalan. Apakah Bapak Ibu melakukan perkenalan atau tidak? Kalau yang dari mahasiswa S2 IKM. Kalau yang lain banyak sudah melakukan perkenalan, ada yang dari dari macam-macam, ada yang dari industri, ada yang dari Kementerian Kesehatan, ada yang dari BPJS, itu cukup banyak ya. Jadi sehingga Bapak Ibu silakan nanti berinteraksi dengan teman-teman yang lain. Nah, sebelum saya dimulai, sebenarnya ini sesi pertama, saya ingin menjelaskan dulu tentang perkuliahan kita ya. Jadi kalau kita lihat konteksnya informatika, memang kita akan berinteraksi dengan berbagai macam keilmuan. Jadi di situ ada bisa jadi kita ada interseksi antara ilmu kesehatan dengan ilmu kedokteran, dengan ilmu informasi, lalu kemudian ada info komputer, ada manajemen, dan mungkin ada statistik dan organisasi, manajemen organisasi, dan bahkan manajemen project. Karena kaitannya dengan project implementasi project sistem informasi di tempat di institusi kesehatan. Nah, nah karena kompleksitas ini, maka kita menetapkan ada 3 learning objective paling tidak di dalam mata kuliah ini. Pertama, bahwa tentu yang paling utama adalah bagaimana melakukan manajemen data dan informasi kesehatan. Nah, yang kedua, bagaimana penggunaan teknologi informasi dan komunikasi itu digunakan untuk mengelola data dan informasi kesehatan. Sehingga Bapak Ibu nanti akan ada praktikum dengan menggunakan aplikasi namanya DIS2, yang tujuannya adalah memperkenalkan kepada Bapak Ibu sekalian untuk sebenarnya ini ada tools-tools yang bisa dipakai untuk mengelola data dan informasi. Nah, kebetulan DIS2 juga saat ini di Indonesia ada beberapa institusi yang sedang menginisiasi penggunaannya, termasuk Kementerian Kesehatan. Nah, dengan harapan bahwa apa yang disampaikan, praktikum-praktikum yang diberikan ini inline dengan apa yang suatu saat nanti Bapak Ibu akan temukan di lapangan. Kemudian yang ketiga adalah ya mungkin sedikit tentang manajemen project atau program sistem informasi di organisasi kesehatan. Nah, utamanya memang yang poin pertama dan yang kedua. Kalau kita lihat dari kegiatan pembelajarannya nanti akan kita bedakan menjadi dua. Pertama kegiatan yang sifatnya teoritis ya kuliah biasa, yang beberapa di antara kuliah itu kita webinarkan. Termasuk hari ini karena kita kedatangan tamu dari luar, ini juga menarik untuk di webinarkan karena tujuannya dari webinar ini juga untuk outreach ke teman-teman yang di luar UGM. Ada beberapa topik, ada 12 topik kurang lebih yang akan kita kuliahkan. Lalu kemudian yang sedangkan tutorial ada kurang lebih 9 tutorial yang akan kita lakukan. Mulai dari pengenalan dari S2 sampai kemudian pengembangan dashboard. Yang pada prinsipnya adalah untuk mengacu pada kompetensi yang kedua, bagaimana pemanfaatan teknologi informasi dan komunikasi untuk membantu Bapak Ibu untuk melakukan pengelolaan data dan informasi. Nah tentu dalam melakukan kegiatan-kegiatan itu kita ada menggunakan e-learning, ya, karena ini Anda berinteraksi dengan barangkali 300-an orang di luar sana, bagaimana cara mekanisme komunikasinya kita menggunakan Gamel. Anda bisa akses dan saya yakin Anda sudah memiliki akses untuk ke sana, di mana Bapak Ibu nanti bisa melihat bahan-bahan atau materi-materi yang dikuliahkan ataupun referensi-referensi yang direkomendasikan. Lalu kemudian ada webinar yang sekarang ini mungkin sedang berlangsung. Ada video kuliah yang direkam khusus yang Bapak Ibu nanti bisa melihatnya kembali. Umpamanya hari ini saya nggak datang karena sakit atau apa, Anda Bapak Ibu bisa melihatnya kembali. Kemudian tutorial interaktif tentu dengan dengan topik-topik yang sudah kita sampaikan tadi. Kemudian ada mekanisme interaktivitas, di mana mekanismenya ini semuanya menggunakan media e-learning. Baik itu nanti ada forum diskusi, lalu kemudian quiz online. Ya. Kebetulan kalau Bapak Ibu kan arahnya adalah pendidikan formal ya, jadi mau tidak mau harus mengikuti ini. Kalau yang lain-lain barangkali kita batasi. Yang di luar ada yang wajib, ada yang tidak untuk yang teman-teman yang dari luar. Tapi untuk yang khusus untuk S2 IKM, kelompok HPM ini semuanya wajib, gitu. Jadi wajib diikuti. Kemudian tentunya ada kegiatan evaluasi dan monitoring dan evaluasi kegiatan perkuliahan. Nah kalau kita lihat statistik pendaftar ini di luar Bapak Ibu, tapi ini 3 minggu atau 4 minggu yang lalu ya, jumlahnya yang dari luar kurang lebih 201 orang. Jadi ada yang mahasiswanya pun juga variasi, ternyata ada juga yang mahasiswa S3 yang mengikuti ini, yang bahkan dari Taiwan, ya terima kasih Bapak Ibu yang sudah mengikuti online course kami. Peserta yang umum ya memang lebih banyak porsinya, kalau dari sisi asal institusinya memang lebih banyak yang dari perguruan tinggi, tapi bukan berarti dari tempat lain nggak ada yang dari dinas, ada yang Kemenkes, ada yang BPJS Kesehatan, rumah sakit, dan bahkan ada yang di industri. Nah, beberapa teman industri memang ya sudah kami kenal dan tertarik untuk mengikuti ini. Beberapa pernah mengikuti mata kuliah ini sebelumnya. Jadi walaupun ada senior alumni-alumni ya, terutama alumni Simkes yang dulu pernah mengikuti ini, dia tertarik lagi untuk mengikuti ini. Karena ada isu-isu baru yang kita sampaikan, terutama praktikum di IS2. Nah, bagaimana interaksi antara Bapak Ibu dengan semuanya yang ada di sini? Ya pertama kita memang ada pesertanya ada beberapa kelompok. Pertama peserta dari mahasiswa S2 IKM dari HPM, lalu kemudian ada teman-teman yang dari individu secara mendaftar sini langsung, ada yang partner ya. Memang kami mengupayakan adanya partner dari organisasi lain, walaupun ini belum berfungsi secara optimal, tapi paling tidak ada mahasiswa S1, S2, S3 dan mahasiswa diploma yang itu terlibat di dalam e-learning kita. Nah, sini kami dari tim penyelenggara, saya sendiri sebenarnya dari awal tadi belum perkenalan malah ya. Nama saya Guardian, kebetulan saya diminta untuk mengelola media e-learning ini, di mana sebenarnya kami mengambil mata kuliah yang itu dikoordinasi oleh Dr. Lutfan Lazuardi. Ya, nanti Dr. Lutfan akan masuk di sesi pertama. Dan beberapa ada teman-teman yang dari asisten dan juga narasumber lain yang ada di belakang sana. Ada Mbak Anissa, ada Mbak Alfrida Abi. Alfrida Abi merupakan alumni Simkes tahun 2000 something, yang saya nggak hafal 2000 something, yang yang mereka sudah mengenal lebih dulu dibandingkan Bapak Ibu sekalian. Nah, ya, teman-teman ini yang nanti akan membantu kita semua untuk mengikuti kuliah ini satu persatu. Nah, tentunya setiap kegiatan itu mesti ada mekanisme monitoring dan evaluasi. Nah, sebenarnya mekanisme monitoring evaluasi ini bukan untuk Bapak Ibu saja, gitu. Tapi ini dalam rangka kami mengembangkan mata kuliah ini ke depannya. Jadi kebetulan mata kuliah informatika kesehatan baru 2 kali ini menjadi mata kuliah wajib bagi HPM. Kami mendapatkan masukan yang sangat bagus sekali dari Bapak Ibu angkatan sebelumnya terkait dengan pengembangan course ini. Nah, sehingga harapannya dari monitoring dan evaluasi ini kita mengetahui kira-kira ada apa kondisi yang seperti apa yang harus kita sesuaikan kembali, apa yang harus kita rubah, apa yang harus kita perbaiki. Nah, karena ini memang bagian dari pengelolaan perkuliahan kita ya. Ada kuliah, tidak hanya kuliah tapi juga bagaimana memperbaiki kuliah ini menjadi lebih baik untuk mahasiswa-mahasiswa, paling tidak untuk Anda di semester-semester berikutnya atau untuk teman-teman nanti di angkatan di bawah Anda. Ya, saya kira ini yang bisa saya sampaikan berkaitan dengan pengantar kuliah. Silahkan nanti Bapak Ibu mengikuti kuliah ini dengan baik ya. Kebetulan kalau Bapak Ibu yang di dalam ruangan ini adalah dari kelompok HPM yang wajib mengikuti karena outputnya adalah nilai mata kuliah. Sedangkan kalau Bapak Ibu yang dari luar juga kami sangat Bapak Ibu bisa mengikuti ini kuliah ini atau mengikuti tutorialnya kalau nanti Bapak Ibu lolos, yang dari luar lolos mengikuti ini lebih dari 80% dari aktivitas yang dilakukan, kami menyediakan certificate of completion ya, dengan nilai bagi yang di luar loh, kalau yang di dalam ini ya nilai hasilnya. Tapi kalau yang di luar certificate of completion yang mungkin bisa jadi salah satu poin ya buat Bapak Ibu yang ada di luar sana untuk entah itu akreditasi atau entah itu untuk skor yang lainnya. Dengan harapan bahwa apa yang disampaikan di dalam mata kuliah ini dapat bermanfaat tidak hanya untuk teman-teman yang ada di ruangan ini, tapi juga teman-teman lain yang ada di luar sana yang dia berinteraksi dengan baik dengan e-learning yang kita jalankan, dengan harapan bahwa ke depan akan ada mata kuliah lain yang bisa dilakukan seperti ini. Kenapa kita melakukan emosi? Sebenarnya ada kerjasama dengan PIKA ya, Pusat Inovasi dan Pembelajaran di UGM. Kebetulan kita mendapatkan grant dari PIKA untuk menyelenggarakan ini, sehingga apa yang Bapak Ibu dapatkan sini merupakan bagian dari dukungan UGM, tidak hanya untuk UGM tapi juga UGM untuk Indonesia. Saya kira demikian yang bisa saya sampaikan. Terima kasih. Untuk selanjutnya, untuk sesi pembuka ini sudah ada tamu. Ini kebetulan dari jauh ya, Swedia dan US, yang nanti akan dipandu oleh Dr. Lutfan untuk memoderatori sesi ini. Baik, demikian dari saya. Terima kasih. Untuk selanjutnya saya serahkan kepada Dr. Lutfan untuk memandu kuliah perdana dari mata kuliah informatika kesehatan. Terima kasih.
Ya, selamat siang Bapak Ibu semua. Assalamualaikum warahmatullahi wabarakatuh. Ya, selamat bergabung juga bagi yang mengikuti secara online. Ya, pagi ini kita akan memulai online course dan juga terutama kalau yang hadir di sini adalah untuk yang mengikuti mata kuliah MKDU Informatika Kesehatan di Prodi S2 Kesehatan Masyarakat. Nah, kebetulan hari ini kita mendapatkan tamu istimewa sehingga ada ya kesempatan juga untuk melihat sebenarnya apa yang terjadi di luar sana, sehingga juga mungkin akan memberikan masukan yang berharga bagi Bapak Ibu semua, terutama kalau terkait dengan informatika kesehatan. Nah, telah hadir di sini Dr. Michael Kwam, Dr. sebenarnya, Dr. Michael Kwam, beliau sekarang afiliasinya dengan Umeå University di Swedia, yang banyak juga melaksanakan berbagai aktivitas terkait dengan informatika kesehatan, termasuk beliau sekarang juga menjadi salah satu researcher di salah satu proyek multinasional namanya Dengue Tools. Mungkin kalau Bapak Ibu bergerak di sistem surveillance dengue pernah tahu, kebetulan Indonesia memang tidak terlibat di penelitian yang ini, tetapi di yang lainnya yang IDAMS namanya. Nah, beliau juga sebenarnya masuk bergabung juga dulunya pada waktu S2 dan S3 tergabung dengan IDAMS. Nah, mungkin untuk tidak memperbanyak menyia-nyiakan waktu, kami ya mungkin akan segera memulai. Ya, Mikael, so I actually introduced a little bit about you, but probably you can also maybe introduce yourself in more detail. So, but I will let you start the session, please.
Is it okay if I stand? Yeah? Okay. And at any time, please feel free to interrupt me, ask questions. I'd like this to be as interactive as possible. Today I'm going to lecture a little bit on public health informatics, but just a little bit about myself. I'm from the United States, but my affiliation and education has been in Europe. I did my first degrees in the US, but then I did my MPH, like you guys are doing, in Germany, in Heidelberg, which was a partner of the IDAMS dengue project. And then I did my PhD in Umeå, which is in Sweden. And so my affiliation currently is in Umeå, the US and Germany. So for today's talk, I have to acknowledge also what brings me here today. Thank you very much, Dr. Lutfan, for facilitating my being able to come to Gajah Mada. This is part of a partnership with Hanoi School of Public Health and Medical University and Umeå University, originally oriented at research links on climate change and health, which is an area of study of mine. I do some teaching on public health informatics and on climate change and health research. So that's what brings me to your course today. So we're going to talk just a little bit about what public health informatics is. And I made a mistake. I thought that your e-learning platform was ELISA, but actually it's different for the medical faculty. So it's the same at Umeå and everywhere I've ever taught. The medical faculty always is one step ahead of the rest in the e-learning platforms. And so I found the wrong one. But I want to acknowledge our friends online, and that e-learning is a huge part of public health education in a formal sense, like those online in the MPH course, but also in a less formal sense in terms of massive open online courses like the MOOCs, and less formal training. So hopefully when you guys finish, those of you who are especially oriented towards public health training of health professionals using public health informatics and teaching materials that involve technology to bring that information closer to home. So the CDC, in its competencies for public health informaticians, defines public health informatics as the systematic application of information, computer science, and technology for public health practice, research, and learning. My focus has been started in public health practice, but more recently has really moved towards research and learning. And I'm gonna break up the talk into 4 elements that hopefully you can see the linkages of practice, research, and learning. This is another definition that I quite like, and this is a really great book that most of it is available freely with Google Books. You know, you miss a page here or there, but it's worth reading even if you don't get it all. And you can buy it, but that costs more. So this is from chapter 20 on public health informatics, but it's actually a book on clinical informatics. It's part of a Springer series. Public health informatics is the application of health information and technologies to improve population health. And this really makes a distinction from other types of health and technology integrations. So public health informatics focuses at its core, just like public health, on population health. So not just on individuals or medical biomedicine for singular patients, but really making that step further to bridging it towards a population health model. But it shares and has a lot of crossover, as this figure shows, with clinical informatics, which is more to do with patient electronic medical health record or technology in clinical settings, with health informatics, with biomedical informatics, and with informatics in general. But the core of public health informatics, I would say that the proportions are a little bit off here. I agree with the way this the author has drawn this, but I think this circle could be much larger, because I think the information that you draw from biomedical health and clinical informatics can lead into public health informatics, which in turn prevents disease on a population scale. And the feedback loops between these become really interesting opportunities for public health informatics in the 21st century. So the key elements that I want to talk about today shouldn't be surprises to you as public health practitioners. I want to start with health and disease surveillance, and I'm going to show a video that does talks a little bit about the history of health information related to health and disease surveillance, and then the electronic medical record, which for those of you who are involved clinically, this is maybe the most familiar health informatics piece, and then a little bit on two more general concepts within public health informatics, data visualization and mHealth. And I think both of these are increasingly important to us as practitioners, researchers, and teachers within public health. So I want to touch on those briefly towards the end. How's everyone doing? Is this okay? Too fast? Too slow? Okay. So I want to ask you guys a question, and maybe just take it in three groups. So the middle group, pretty easily, the whole group, the side group, and this group. I want you to think about public health informatics, and one example for the side group of public health informatics in practice that you can think of. Yeah. And in the middle, research. And on the side, teaching or training. Okay. So just take 2 or 3 minutes, talk amongst yourselves, and see if you can come up with a quick list of examples within each of these. Okay? Ready? Go.
Why?
Because it's 20 minutes long.
Okay.
Maybe I showed just a little part of it. I don't know.
Yeah, it's depend on you guys.
Is it going okay? Is that okay so far?
Yes, yes.
I'm not getting into a ton of detail.
Yeah, probably. Yeah, I mean, if you like to, so maybe yeah, you can select the main message that maybe.
I really do like this one though. So they seem to be talkative. That's good.
Yes, yes, yes.
Do you think you could facilitate the discussion of their answers
Yeah.
so they can speak in Indonesia?
Yeah.
Okay. Let's start that.
Yes. Sudah.
Okay. We're going to come back to the group now, and Dr. Lutfan is going to facilitate the discussion around these three topics. So.
Sudah siap, Bapak Ibu? Mungkin yang sudah ada di bayangan saja. Jadi ya saya kira untuk memicu diskusi selanjutnya, mungkin Bapak Ibu bisa memberikan respon tadi. Tidak harus dalam bahasa Inggris kalau ya, Bapak Ibu merasa mungkin. Tapi kalau mau silakan dengan senang hati. Ya.
Laporan. From this group, we'd like to say that the application from public health information in practice is already implemented in health ministry, especially in Indonesia, like report system that already in the web, and Android application and also iOS applications, and also the what is and electronic medical record is already in a system, one system, and then there is this health information system in a region that already been implemented from bottom to up, so that everyone could see it in the website. That's the and also the data analysis and billing system already in electronic side. So that's the health information public health that already implemented from our group. Thank you.
Informasi-informasi kesehatan yang bisa digunakan untuk penelitian kalau di Indonesia dari tingkat level bawah itu ada pemantauan wilayah setempat atau PWS, itu dari lingkup dinas kesehatan provinsi, kabupaten sampai puskesmas, itu ada informasi lengkap tentang kesehatan, tentang apapun juga, kesehatan lingkungan, KIAKB, banyak sekali, dan itu bisa digunakan sebagai sumber informasi untuk penelitian. Dan akan ditambahkan teman saya.
Oke, mungkin untuk yang contoh lainnya yang lebih besar dari PWS tadi adalah Riskesdas. Yang kita tahu Riskesdas itu surveillance tingkat nasional ya, yang memang dilihat dari gambaran seluruh populasi di wilayah Indonesia dari Sabang sampai Merauke, dan itu akan dikumpulkan menjadi satu dalam sebuah hasil data laporan kesehatan Indonesia yang bernama Riskesdas. Seperti itu. Itu untuk contoh research ya.
So they mentions the data that has been collected through the surveillance system, and also there are some activity related to the population-based surveillance, like we call it Discuss. It's the National Health Survey, which is done by the Ministry of Health. Okay, so the next group, training.
Ya, dari grup kami, contoh penerapan public health informatics dalam ranah pembelajaran. Di sini informasi public health ini bisa digunakan untuk e-learning yang tujuannya bisa untuk penelitian, untuk apa, monggo ditambahkan Mbak Gung Sri.
Kalau untuk tambahan aja, kalau untuk dalam ranah teaching atau pembelajarannya itu mungkin karena sistem informasi bisa membantu untuk memberikan informasi-informasi dari penelitian terupdate, jadi itu bisa menyebarkan informasi kepada masyarakat secara umum, secara menyeluruh. Nah, untuk trainingnya sendiri itu terkait dengan peningkatan skill dari masyarakat yang dituju. Gitu. Jadi melalui sistem informasi itu sendiri nanti bisa diinformasikan kepada sasaran ataupun masyarakat di sini untuk peningkatan skill dari beberapa sumber yang bisa dimasukkan ke sistem informasi tersebut. Bisa ada yang... Sekian, terima kasih.
Kegiatan pengembangan kapasitas difasilitasi oleh sistem informasi dan teknologi informasi ini yang so they mentions that nowadays the activity to build the capacity is also use the information technology and informatics technology.
Well, I'm so glad to hear that that so much part of the ongoing practice, research, and training schedules within your communities and here at Gajah Mada already use public health informatics. To go off of the last group's statement, I want to show a video. I won't show the whole thing, but I encourage you to watch it later. It's about 20 minutes, and it's just a little bit of a teaser into the history of health informatics and how it relates to disease mapping particularly. So let's see.
So when I signed up to do this
And this is from Thomas Gates. He's an editor at Wired, which is a pop science computer magazine. Let me see if I can find it. There it is.
months ago with Brady, I'm working on this new book on tuberculosis and kind of the attempt to cure TB. And I thought, I'll just do a sweep of how location matters in infectious disease. And it turns out that if you want to do a presentation on infectious disease through location, it's pretty much the history of the world. So, so I thought that was probably a bad idea. I'm not going to be able to fit the history of the world into 20 minutes. So instead, I thought I would start very local and just try to narrow in on this idea of kind of what, how powerful location is in disease. And I want to start out right here in San Francisco. So there's this awesome story that really tells the story about how location matters. Right at the turn of the century, 1900, there was a boat coming in to San Francisco, a lot of boats coming into San Francisco at the time, and this one was filled with Chinese immigrants, and it had a couple people with the plague on the boat. And so they took the boat and they immediately sent it to here, to Angel Island, which was the quarantine station. It was the West Coast equivalent of Ellis Island. And so they put the boat in quarantine and had everybody come down.
Is quarantine Understood? Do you know what quarantine is? Okay. So this was a long time ago, but quarantine was already a standard practice for, in this case, immigrants coming from a different country into the west coast of the United States. When I was flying in, I immediately saw the quarantine and medical office within the airport in Jakarta. This is standard practice even today.
On this dock, this is the dock is, you can still actually go see this. The dock is gone, but the forts are still there. So they quarantined the boat, they stuck it there, and then they had the people walk off like this. These are Japanese women and then Chinese men behind them. But at the same time, so they came down and then they went into a building and were quarantined for a few months. Now what happens, quarantine is actually this great little phrase, it comes out of the Italian word quaranta, which was the 40 days that when a ship came into Venice in the 14th century, it would have to be stationed and stay in port for 40 days before any of the soldiers could come off. Now they didn't know why disease came on ships, right? They didn't know of such a thing called germs, but they knew that when a ship came in, sometimes disease came with it. So they created this idea of a quarantine, which is actually what they put in effect here. The problem with quarantines is that they're, especially before before the germs theory existed, they didn't really know what was on the ship that was going to cause disease. So in the case of this boat, even in the couple of years after the germ theory, they couldn't account for two things that were on this boat, other than the people that they had accounted for. They couldn't account for the rats, which are kind of well known as today as the conduit of plague, or the vector of the disease, and then the stowaways. So with rats and stowaways, the ship may have been quarantined, the official passengers may have been quarantined, but the actual disease was not. So what happened is the disease went from Angel Island all the way to Chinatown. And so there was an outbreak of plague in Chinatown. Now, they weren't sure about it, right? They were just kind of reports. It was rudimentary health tracking. The sanitation department in the city of San Francisco heard reports that there was plague, but they didn't have any proof. They didn't have any evidence. And the idea of disease, the idea of a disease like plague in the United States, it had never been reported before. And so this was a big deal, especially for the city leaders of San Francisco. And so the business interests said that no, there's no such thing as plague in San Francisco. The governor of the state of California said no, there's no plague in San Francisco. The press said there's no plague in San Francisco. There was kind of a rallying around the idea that no, San Francisco is fine, plague is not here.
Just want to highlight a few important points from those last bits of the video. So one, you saw the map and where the quarantine station was, and then moving down to Chinatown. So mapping, so when and where disease happens, and from historical analysis, it was based on reports from individuals presumably getting sick. This is a key part of any surveillance system, is detection of disease. This was before we knew what the plague was, other than people died from it. And the quarantine practice went back to, I think you said, the 14th century, so many years before we had larger public health efforts, at least organized governmental public health efforts in the United States, at least. The third point, and maybe an especially important one, is that public health informatics and public health in general operates often within a context of a government. In this case, the mayor, the governor, maybe even other bodies said, oh, there's no plague here. So even though there was evidence to the contrary, the government said there's no plague here, therefore the action to reduce it initially was also slowed. So the governmental context can be an important part of a surveillance system. What's allowed to be reported, what's allowed to be resources be mobilized for. So that should also always be a part of your planning and understanding of how a surveillance system works. It has to work effectively within structures and cultures as they are occasionally pushing those boundaries for the purposes of public health. And this is as present today with the Zika pandemic and Ebola pandemics of recent past as it was then with the plague. There are some political movements against initial reports that sometimes delay public health response. So, I would like to continue to watch this video with you, but I think for time I'm going to move on. This link is provided, as are many others, with the resources from this lecture. So in its most basic form, epidemiology is the study of whatever happens to people within a place. Detection, description, data collection, and coding of relevant population health information are central features to any public health system. I think by its very definition, by its very name, this is epidemiology, this is public health. Surveillance is a core piece of that, looking at what was or what is the normal occurrence of health and or ill health in a place at a particular time, and seeing how that changes over time and place is the beginning, the cornerstone of any population health efforts. This pretty common definition of surveillance. Here, ongoing and systematic is important, so that results from place to place and time to time are able to be compared. And this is where a public health information system like electronic medical records or health information integration becomes so much more important. Having a common language and a common definition time after time, place to place, makes it possible to identify patterns, identify abnormalities, and ultimately stop the source of ill health, to put into place public health action. But it can also be seen on the positive side. You can do positive health surveillance, not just disease surveillance. You can look at healthy trends among populations. You can look at things that produce more healthy people, more longevity, and repeat those patterns elsewhere as well. What the benefit, to go back to the historical side of looking at healthy practices, is you don't have to fully understand how disease manifests. So with the plague, we didn't know that there were rats involved, or for that matter, lots of other microbes involved before Koch's postulates. We didn't really have an idea of where disease comes from. And with a lot of modern non-communicable disease, we don't have as much specific information about how these diseases manifest themselves in higher rates in some populations than others, in some places than others. And so taking practices that work can be something that's supported by a public health informatics system long before we understand the biomedical solution or the etiology of disease or the natural history. Again, focusing on reducing mortality and improving overall health. So in short, detecting epidemics, creating effective control measures, understanding the natural progression of disease. If we don't measure it, we don't know it. We don't have an opportunity to understand it as well. Monitoring changes in infectious agents, gaining planning information, and stimulating research. But basically, surveillance is asking these questions. It's when, where, who, and regarding health. So, to make the link to the electronic medical record, why are health information systems so important? Well, essentially, they're the foundation of public health action. And in a modern era, it's being demanded more and more of us to improve our accountability and ensure evidence-based practice. So this is more on the individual health side, but also gets expanded into population health. As you've already said, there are some electronic medical records in practice here. Just going to show another quick video or two on what an electronic medical record is and its benefits that may be going beyond its current practice here.
This is Peter J. Pollack, MD, for Medical Practice Trends, and welcome to another EMR Simply Put video. In this issue, what is EMR? EMR means different things to different people. Electromagnetic radiation weapons, or paintball guns, or a rock band. Oh, sorry, that would be EMF. Or electronic medical records. This is the one we're talking about. An electronic medical record is simply a scanned digital version of a paper medical record. An electronic medical record system is a computer-based database system specific to one physician or organization. It is the digital record that a doctor maintains on his or her own patients, detailing personal information, medical history, and a list of diagnoses. The information of the individual typically integrates with the physician's practice management software system that handles scheduling and billing. Now, let's look at the two main types of EMR systems. Number one is a server-based EMR system, one that is typically located on the practice premises on a specialized computer called a server. Number two is a web-based EMR system, which is generally located off-site on the EMR company servers, and the medical practice accesses it via the internet. This is also known as software as a service or application service provider. So now you know what EMR is and the two main types of EMR systems. In the next video, we'll discuss the pros and cons of each type.
Hi, I'm Kaz Matsune, the owner and executive sushi chef of
This is Peter J. Pollack, MD, for Medical Practice Trends, and welcome to another EMR Simply Put video. In this issue, what are the benefits of having an EMR system? Besides incentives for implementing EMR and penalties for not doing so, what are some other benefits of having an electronic medical record system in your practice? Here are 17 to name but a few. Number 1, charts are more legible. Number 2, charts are always accessible, even from home. Number 3, enhanced documentation with access to digital imaging and special testing. Number 4, better integration between the clinic and the business department. Number 5, improved efficiency and better communication both within the practice and between different practices. Number 6, improved coding and compliance. Number 7, enhanced patient safety regarding drug allergies or interactions and proper dosing. Number 8, improved tracking of laboratory information. Number 9, tracking of trends such as blood pressure, blood sugar, or intraocular pressure. Number 10, transcription cost savings. Number 11, medical record staff savings. Number 12, savings on pulling charts. Number 13, savings on office physical space. Number 14, paper and toner cost savings. Number 15, medical chart transportation savings for multi-location practices. Number 16, good for marketing as your practice is seen as cutting edge. And number 17, better disaster recovery as a practice with EMR and proper backup plan could come back after a disaster while a paper-based practice could be wiped out. We're probably leaving out several more, but you get the idea. So now you know the benefits of having an EMR system. In the next video,
All right, I'm going to turn it over to you guys for another discussion. I want this half of the room to think of 3 more benefits that weren't in the video to an EMR here that specifically address public health. So not just an individual patient or the medical providers, but public health benefits of an EMR. And I want the rest of the room to get together for 3 reasons that an EMR is maybe not beneficial to compared to physical records. I think I have a picture of those somewhere. Compared to these. Okay, so
Ya, jadi Bapak Ibu yang kelompok di sini mungkin bisa memberikan 3 contoh tadi benefits yang terkait dengan public health. Terus kemudian yang kelompok selanjutnya ya apa mungkin lebih terkait dengan kenapa so what was the this one is the public health benefit. Ya, jadi yang di sana kenapa mungkin lebih bagus yang paper based ini. Silakan Bapak Ibu. Ini sebenarnya mungkin sudah bisa langsung direspon juga, silakan.
Nemu 2. Manfaat di pabrik.
Kalau tes, ya kalau keuntungan dari paper base itu kalau untuk negara kita secara menyeluruh Indonesia itu karena sumber daya manusianya memang kok tidak semuanya punya kompetensi untuk komputerisasi. Jadi itu menguntungkan, bisa dilakukan di semuanya, semua daerah. Yang kedua, ya sarana prasarana, logistik, instalasi listrik, bahkan ada daerah yang memang belum ada listrik ya. Jadi Iya, servernya juga. Aduh, jaringan internet banyak sekali. Intinya logistik masih kurang. Belum bisa mengcover semuanya. Ya, ya. Jadi kalau kertas lebih efektif kalau untuk seluruh daerah Indonesia gitu ya. Apalagi teman-teman. Ringkes apa ya, nggak beribet gitu kalau untuk orang yang mungkin biasa semuanya bisa lakukan lah gitu ya dari seluruh tataran pendidikan gitu ya. Udah gitu aja.
Ya, bahasa Indonesia saja nggak apa-apa ya. Ya, untuk tiga keuntungan lain menggunakan EMR, yaitu yang pertama integrasi dari rumah sakit, integration hospital and ministry is more fast. Faster ya, faster, oke. Untuk itu yang pertama. Lalu yang kedua, penampilan data ke website lebih cepat. Jadi orang umum bisa melihat data penyakit itu dengan cepat, hanya dengan membuka website. Oke, yang ketiga, pengelolaan data dan pemetaan penyakit juga bisa dilakukan dengan cepat. Dan ini untuk keuntungan lain bagi personal, bagi pasien, yaitu billing sistemnya lebih cepat karena data lebih cepat masuk ke server ataupun kalau dia menggunakan web base ke web base tersebut. Terima kasih.
Yeah, so in general you mentioned that there will be more faster in terms of the data analysis, data integrations, and also the visualizations.
Great work, both groups. So I just want to repeat from the paper-based group. So it was literacy, like computer familiarity. Okay, and the other topic was electricity. And what was the third one? Okay. 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 So infrastructure related, similar to electricity, but infrastructure. Yeah. Great. I completely agree. I think the other reason is we've always done it this way, and that might be a really strong one for a lot of facilities. The resistance to change can be an important hurdle moving over to electronic medical records, in my experience. But I think mHealth might have a lot to offer that addresses those drawbacks of paper, because I think, well, we'll just do a quick show of hands, or better said, a quick show of hand phones. Can everybody pull out this thing? Does everyone have one? Yeah. So this addresses most of the electricity and networking issue. Maybe not today, maybe not everywhere, but pretty close in the very near future. Assuming that we can get things smaller scale and secure. So I'll talk a little bit more about mHealth at the end.
Bapak Ibu yang online, kalau ada komentar atau pertanyaan bisa juga disampaikan dengan mengangkat jari dari ini webinarnya.
Okay, so going back to the familiar slide from Haig et al. So electronic medical records are really more about clinical informatics and health informatics. But they fall into a busy array of other pieces of clinical and public health practice. They involve a lot of different skills, and I just want to highlight a couple things here. Coding and classification is an important part of any medical record system or any health information system, whether or not we're talking about an electronic one or a computer one or a telephone-based one, or even a mobile or app-based. We need to be in a position with an electronic medical record or any health information system to have common language. And this is really where the benefits to the public health system come in, because we need to be able to integrate information from a single provider or a single patient who's ill or well with all of the other patients who are ill or well, and for that matter, with all of the people who don't enter the healthcare system at all. And that's where the real public health interventions that are data-driven are available. So that all starts with coding and classification. Is coding a clear concept? Do you know what coding is? Can someone give me an example of a code, a medical code? Perfect. ICD-10. Yeah. So is that the standard here? ICD-10. Yeah. Okay. And so it's about identifying a specific product or service, grouping things together. Can also be about identifying specific diagnoses. Coding has its enemies in medical practice, because I don't know how complex the coding structure is here, but in the United States and in Sweden and in Germany, and even in the small clinic in Honduras where I first started working, the code book was very thick. It was too difficult for a provider to understand all the interlinkages immediately. And so you started to have code packages, and you had people who've made their profession in medical coding. So sometimes coding is very good, but sometimes coding gets to be so cumbersome and difficult for physicians to practice. So there is a balance with coding and classification and grouping, and having hierarchical systems and regulatory systems that address this in medical provider training makes it a lot easier. Building a culture of coding makes things a lot easier. So here's an example from one of Lutfan's lectures. You have these 6 conditions, and you need to classify them. So can anyone guess where? Let's say HIV is category 1. What else would be category 1 if HIV is category 1? So you have, if this one goes here, what's similar to HIV in this case? Tuberculosis. Okay. Why? Okay. Because they're both communicable or infectious diseases. Okay. Yeah. Okay. Which other 2 would go together? What would go with traffic accident? Drowning. Okay. And why is that? Trauma? Trauma, okay, yeah. Accident, injury, trauma. It's something acute and, yeah, happens like that. And breast cancer and hypertension are what's left. Those would be together. Why would those be together? Okay. So now I'm going to ask you a different question. Which one or two would also be with breast cancer and hypertension? Okay, why traffic accidents? I agree with you, but why? Okay, so one reason of coding could be that it's according to how much mortality, morbidity. The reason I would see cancer, hypertension, and traffic accidents linked together is because the built environment might be a responsible part of the disease-causing process. It might be that you can solve all three of these, at least in part, with a healthier built environment, with a healthier transportation infrastructure. That could be another way of coding your diseases, of associating like with unlike for public health purposes. I similarly would say HIV might fit with both of those because it's a chronic disease. So although it's an infectious disease, it's generally a lifelong management disease. So I see HIV and hypertension also have some similarities in terms of how they are addressed in a health system. So thinking of how we associate like groups together and how we analyze the morbidity and mortality of a given disease, this also has to do with what kinds of public health solutions we put in place, what kinds of training opportunities we find important as a society. So public health informatics, even with this simple example of 6 disease states, can be applied very biomedically to each one individually, or greater solutions on a population scale could be planned from knowledge about these. So just to highlight, there might be a gradient between these, right? But you guys hit the grouping on the head. No explanation needed, right? This is a very organized paper-based record that I grabbed from one of Lutfan's presentations. I've seen it a lot worse. I've lived it a lot worse than this. So I'd be pretty happy with that, actually. I'd prefer it to be electronic, but this is rather legible.
Well, there is comment also from the online participant, Bapak Abdullah Jamaluddin, which is also mentions that the paper-based is more often used here, since that because of the human resource, the competency, and also the habit, which is and also for the administrator, they prefer to use this the paper-based to check, to verify, instead of having this EMR, the electronic system. And also, although the EMR probably will also be very useful when we then would like to do the data analysis further on.
Thank you for the comment from the student online. That's absolutely. I think there's benefits to paper-based systems as well, but I think ultimately the world has started to move away from paper-based medical records. Some places are still doing dual record keeping. And there's some argument for better patient relationships, at least within the provider-patient interaction, with a paper-based system because of the literacy of physicians. But one of the problems with Paperbase, as the online user and Dr. Lutfan just explored, when it moves to analysis, moving from this to what's that, about 10,000 different health sites that might collect something similar is a very difficult process, a very time-consuming process, a very expensive process, and when you move outside of the Indonesian context, there's even more languages than just in Indonesia. So the other benefit to electronic medical record systems is potentially some of the data inputs can become automated and interlinked. So if a patient, say a chronic disease patient, is coming in for their 10th appointment this year, you don't have to lose time on inputting all the information that you would normally do. You gain a lot of efficiencies because you have that record already in place. It's already there just with their card or number. And again, electronic medical records are not necessarily, as the video showed, landlocked in-house computer systems in a room somewhere with only one person who knows how to use them. More and more mobile technologies, tablets, phones, etc., have apps that allow for electronic medical record storage and input. And a lot of this can even be assisted by patients or the population themselves. So the data collection is really moving more and more mobile, as is the real-time analysis. So data visualization is a big part of public health informatics. The field is all about data, right? There's just tons and tons of it, and more every day. And the more I look around the room right now, and people are taking pictures, that's data. That's a lot. You know, the number of pictures that were taken in the last year are probably only slightly less than all of the pictures that were taken in time before, because now everyone's a photographer, and we don't really feel the need in the same way to value data when it's being collected and collected and collected. So when you have a lot of it, data management and data visualization and communication with your data becomes a core competency of a public health informatics professional. So, and this is true whether you're in practice, maybe you're a health informatics professional at a hospital, but there's still going to be, for your patients, for your physicians, for your coworkers, times where you need to present the data that you're compiling, that you need to present and have a user interface for the electronic health record. In research, visualizing your data and analyzing your data is synonymous. It's probably the most important way to communicate research to other researchers, to students, but also to the public. And lastly, the public is maybe the most important user of the data that we collect as public health informatics professionals. Okay, so back in the small groups again. Just want you to take 2 minutes and talk about how we use data visualization in public health informatics, or in public health in general. Just really quickly. We won't share it out. I just want you to take a few minutes and think and talk about data visualizations. All right, so I'm going to go on, but hopefully those discussions will continue throughout the time in your masters. So in public health, we clearly use data visualizations for communication. So this is an informatic information that I saw right before my partner contracted chikungunya in the Caribbean. And there's this outbreak of chikungunya going on, and even though I studied chikungunya, I was like, well, we already have this trip planned, we're going to go there. One of us is going to come back with chikungunya. Oh well, she got sick. This is another visualization, and public health informatics isn't always about visualizing data. So this is a more educational. This is even pop education. This was in USA Today, which is a newspaper, and it was used to educate the public on how healthcare providers were changing their guidelines for what they wore in response to Ebola. It's very simple, but again, this is a computer generated image. Sometimes it's even less words, less information, but just priorities that come across through data visualization. So as a researcher, I'm using data visualizations all the time to explore my data, to explore models of causality, to understand relationships between things. So from an analytical standpoint, it's really hard to look at spreadsheets of numbers and words, but it's a lot easier when you try to abstract them into something more simple, simply to explore and organize your ideas. Maps are also a big part of data visualization. This is an online system for dengue reporting. This is automated through HealthMap. Sometimes data visualizations are used to organize ideas that are known about how it transmits. So this is the natural history and vector history of malaria. One other link I have for you. This is the periodic table of visualizations, and each one of these elements is a different kind of chart or map. So you can explore this on your own, but I'm just going to show you the link. So if you explore around, you might find some ideas about different ways to organize information.
Six million phones in people's pockets globally, and chronic conditions the largest cause of death worldwide, we're starting to see major innovations in mobile technology. From mobile apps that use games to make carb counting fun, to those that quantify mood fluctuation based on physical activity, it's exciting to see mobile solutions creating innovative new tools for managing health. What's even more exciting is the unlocked potential if these tools were more easily integrated. Combining and comparing different health measures allows the relationship between them to be more accurately understood. From helping a doctor see how a patient is responding and enabling them to appropriately adjust treatment, to helping patients see and understand how their behavior impacts their health and reinforcing healthy changes, to even allowing the impact of the technology itself to be proven. The potential insights and powerful feedback loops created by combining data sources is huge. But most mHealth solutions are being built in silos, which makes integration difficult. Open mHealth is building an open architecture to break down the barriers to integrating different data sources. Through a shared set of open APIs, compliant methods, software modules, and applications, data can be configured to produce more effective solutions. Apps can be more effectively integrated at every level. Data processing modules can pull data streams from an array of sensors and application sources and combine them along shared parameters, such as time or location or physiological measure. Visualization modules allow easy interpretation to reveal invaluable correlative insights, such as how medication affects energy and sleep. Evaluation modules can be embedded directly into apps to allow real-time assessment to quantify the clinical impact of an app itself. By enabling integration at every level, the potential for mHealth to truly transform healthcare across the board is infinite. Through an open community of developers, health entrepreneurs, and professionals, we want to build together more effective mHealth solutions for all.
So really the future of public health informatics is already here. mHealth is really where things seem to be moving. There we go. So the WHO back in 2011 made this statement. As of last year, there were already over 100,000 health-oriented apps available on Apple's iOS and Android systems. 100,000 different systems. I mean, between the phone's ability to take inputs that we put into it directly and its ability to take inputs that it's already measuring in real time, to wearables, just the quality of the cameras and the speed of data that can be transmitted from phone to phone or into cloud for computing analytics is a new frontier. I've seen applications of diagnostics that are barcodes. You just take a picture and it inputs everything. I've seen examples of wearable technologies, watches, shirts, even glucose monitors that are embedded. There's a great deal of applications. The oldest mHealth application, I don't know, but one of the early ones that I was familiar with were SMS-based messaging for health promotion among pregnant mothers. And when I was exploring UGM's website, I found a little bit of a story on maybe a project of one of your colleagues. This is basically an SMS-based patient queue. So basically the idea is that you reduce waiting time and increase efficiency by not going to the health center until it's close to time for you to make your appointment. At least that's my understanding of it. But I only had Google Translate to help. Google Translate, I mean, how cool is that? And these are the folks I think that that came up with it. So again, so public health informatics is really right here with the SIMCAS and with the master's program in public health informatics and all of the great work going on here at UGM. So that's my talk for today. I can take questions if there's still time.
Ya Bapak Ibu, jadi itu tadi yang disampaikan oleh Dr. Mikael. Jadi ada beberapa hal tadi yang difokuskan ke disease surveillance, health surveillance, terus kemudian juga terkait dengan electronic medical record, terus kemudian data visualizations, dan yang terakhir terkait dengan mHealth. Ya sebenarnya mungkin ada banyak isu, tapi ini sebagai pembuka terkait dengan mata kuliah health informatics yang sebenarnya juga skopnya sangat luas. Nah mungkin dari yang disampaikan tadi ada waktu untuk 1-2 penanya. Silakan Bapak Ibu kalau tertarik bertanya, silakan. Ya silakan. Ya mungkin kalau bisa langsung disampaikan saja sambil nunggu kalau nanti ada satu penanya lagi, terus setelah itu.
First, may I introduce my name? My name is Rudy. Mr. Michael Kwan, nice to meet you. Here, I feel really lucky to attend in this study today. We learn about public health informatics. Excuse me, I'm working at a hospital in Bengkulu. There, we already use that local area network in hospital, but I think if we compare to benefit and then lack of skill in my hospital, maybe it's make our job at hospital not make any big difference if we use paper based or this system informatics like that, because lack skill. And then the director of hospital already tried to do joint training here in Yogyakarta, but it is not make any difference. Still stuck. That problem, I think, first in server, to also sometimes network problem, and then about electricity, alhamdulillah, it is not problem. On time, if electricity shut down, we have genset generator. But I think really not big difference, sir. Until now, medical record is not electronic. Still use paper based. We call in hospital status patient. And when we wanted to do research, we must open again all document in so many file like that. It's make me I'm pharmacist. so difficult to get data. And then how we can do research about, there is pharmaceutical research about, interaction, how we make it is adverse drug reaction, patient have adverse drug reaction in hospital, it will be minimized like that. And then third, oh my God, the really big problem search until now. If we make report at hospital, there is data there in that system, local area network, but it's not solve our problem. There is data and then it's not finished. It's not complete our solve. We must take all data around us, from radiology and then from medical record and then again from prescribing also. We must try again, make it, complete, use manually, Excel program. I don't know what's the problem of in this hospital. I think maybe you can give advice. I hope next in hospital can use this like this. It's really good. It's really good idea. So if next time you need again, like core studio, maybe we can use this. Is not much, open again, file like that. Thank you so much. Or maybe you can also give me some recommendation, for tutorial for this program. Inshallah, I will talk again. I will try to explain to my colleagues at hospital. Thank you so much.
Ya, terima kasih. Jadi saya kira tadi pertanyaan yang menarik. Jadi sekarang sebenarnya itu sudah ada inisiatif untuk menggunakan electronic medical record, tapi masih ada kendalanya ya. Jadi memang lebih mudah dengan paper based, tetapi sudah melihat potensinya ya, melihat ya.
It's make really difficult to us as pharmacists to here written. Oh my God, so difficult to read. And also when we see this is children, while like this dose, is maybe in written actually it's 5 milligrams, but we read it like 15 milligrams, like overdose like that. If the prescribing can electronic also, it's make any big problem. Like that.
Baik. Would you like to give a response to the question?
Sure. I'll comment briefly on a few of those points. I think in general, hospitals and health centers have a great deal of difficulty in making changes on this scale, especially in a context where so many of the employees respond. Where so many of the employees responsible have limited computer skills or computer literacy. I think that's a huge problem in almost all settings, and I think it's mostly a generational problem. It becomes less and less with each new hire, just because the prevalence of experience with computers and computer-aided technology is increasing. Interoperability is a huge problem between the silos of different kinds of systems. Even if there are electronic medical records, they might not speak well to each other across department, across discipline, or in they might not be well planned or well put out. I think the solution there has to do with more intentional planning and training around the implementation of a new system. Organizational change, policy change is always a very difficult thing, and getting everyone onboarded is maybe impossible, but it helps to make that attempt and train. And some of the newer systems are more streamlined and more able to cross-query to make that easier. I feel like that you've touched on a very difficult part of public health informatics, and certainly one that would require more training for your facility.
Ya, nanti mungkin juga akan ada bahasan yang lebih spesifik menjawab pertanyaan Ibu di sesi selanjutnya. Ini berhubung keterbatasan waktu juga, there is one, actually two questions, but probably we will answer only one, and then we will continue the discussion through the online system. So this is a question from Nurul Huda Triana. Don't you think this exchanging personal data cross-platform will cause to violations of privacy?
Absolutely. So, data security and privacy and confidentiality is a huge part of public health informatics, especially as it relates to individual. I think there again, proper planning, training, and attempts made to reduce risk are absolutely necessities in building and planning a system for wide-scale implementation. It's not significantly different with paper-based applications, but it is easier with paper-based applications to understand where they are physically and to an extent in time. And cloud-based solutions offer more accessibility and therefore also more risk of misuse.
Ya, ada satu pertanyaan lagi dari Pak Ditya Permana Adi yang ya mungkin ini kita nanti gunakan untuk bahan diskusi selanjutnya juga karena lebih ke konteks di Indonesia. Jadi pertanyaannya terkait dengan bagaimana regulasi terkait dengan ERM di Indonesia yang mungkin karena berhubung waktu juga dan juga mungkin Mikal tidak tahu banyak situasi di Indonesia akan kita diskusikan secara online. Baik, ya saya kira itu Bapak Ibu semua karena waktu hari Jumat juga jadi mungkin kita harus akhiri sesi ini. Terima kasih sekali atas partisipasinya dan mungkin juga untuk menginformasikan dari terkait dengan data visualization, salah satu yang sangat terkenal itu adalah Han Rosling, a physician from Swedish, which is actually create very interesting graphic visualizations called Gapminder. Mungkin nanti Bapak Ibu bisa melihat di sana. Okay, so thank you very much, Mikal. It's I think wonderful time to be here and also to share the knowledge and experience that you have. So applause untuk Pak Mikal. Terima kasih. Selamat siang. Assalamualaikum warahmatullahi wabarakatuh. There are actually some online questions, but due to the time, then we will continue